When treating patients, especially those with diabetic kidney disease and general kidney disease, it's clear how crucial proper management is. These conditions significantly impact the prevention of atherosclerosis and are closely tied to the patient's survival. Nephrologists often prescribe highly effective medications for this purpose, but in Koreatown, I've observed that only one other doctor, besides myself, prescribes these medications. Consequently, they are often unavailable in pharmacies. Even pharmacists sometimes misunderstand these drugs, mistaking them for antacids, leading to frequent dispensing errors. I've encountered situations where pharmacists called me to confirm if the medication was for the stomach, which has happened multiple times. In some cases, pharmacies substituted the drug entirely with an antacid, creating misunderstandings that were both absurd and frustrating. This medication story from 10 years ago highlights the challenges of awareness and proper dispensing. Today, I'd like to explore this topic further by sharing a clinical case. A 68-year-old female patient visited our clinic. She had a history of type 2 diabetes, kidney disease, hypertension, and gout. She became concerned after reading online that a creatinine level of 1.5 indicates stage 3 chronic kidney disease. Upon visiting our clinic, her blood test results revealed sodium at 136 millimoles per liter, potassium at 5.6 millimoles per liter, bicarbonate at 17 millimoles per liter, BUN at 75 milligrams per deciliter, creatinine at 1.5 milligrams per deciliter, HbA1c at 7%, and LDL cholesterol at 135 milligrams per deciliter. Additional tests showed calcium at 9.2 milligrams per deciliter, phosphorus at 4.8 milligrams per deciliter, albumin at 3.8 g/dl, uric acid at 7.8 milligrams per deciliter, and urinalysis showed 1+ proteinuria. Her medications included glipizide, 1 mg twice daily, for diabetes, amlodipine, 5 mg, and atenolol, 50 mg, for hypertension, atorvastatin, 10 mg, for hyperlipidemia, along with sleep aids and vitamin D supplements. This was her first visit to our clinic, and several issues in her treatment plan required immediate attention. First, her LDL cholesterol level of 135 mg per deciliter was far above the target of less than 70 mg per deciliter for diabetic patients. She was only prescribed 10 mg of atorvastatin, which was insufficient. To effectively reduce cardiovascular risks such as stroke or myocardial infarction, her statin dosage should be increased to at least 20 mg daily. Second, her hypertension was being managed with amlodipine, a calcium channel blocker, and atenolol, a beta blocker. These are not the preferred first-line treatments for diabetic patients with hypertension. Current guidelines recommend ACE inhibitors, ACEI, or angiotensin receptor blockers, ARBs, as primary choices due to their protective effects on the kidneys and cardiovascular system. Diuretics or calcium channel blockers like amlodipine are considered secondary options. The absence of ACEI or ARBs in her regimen was a significant oversight. Third, she was prescribed glipizide, a sulfonylurea, for diabetes management. However, for patients with kidney disease, newer medications like SGLT2 inhibitors, e.g., empagliflozin, or GLP-1 receptor agonists, e.g., liraglutide, should be considered, as they offer additional benefits for cardiovascular and renal health, depending on her kidney function and overall condition. The patient stopped metformin due to concerns about kidney function. However, at that level, metformin can still often be used, depending on the situation. 8 years ago, SGLT2 inhibitors were not widely prescribed, especially in Koreatown, where only a few doctors, including myself, used them. Today, treating diabetes with just glipizide is insufficient. For patients with diabetes and kidney disease, SGLT2 inhibitors are strongly recommended by major medical societies due to their benefits for kidney and heart health. A critical issue in this case was the patient's bicarbonate level, which was 17 millimoles per liter, indicating metabolic acidosis. Unfortunately, this condition is often overlooked by general practitioners and left untreated. Metabolic acidosis, if not addressed, accelerates kidney damage, worsens atherosclerosis, and leads to severe health complications. It's one of the reasons why early referral to a nephrologist is essential. The kidneys play a crucial role in maintaining the body's acid-base balance. When kidney function declines, metabolic acidosis can occur, disrupting this balance. It's diagnosed when bicarbonate, HCO3, or CO2 levels are below 22 millimoles per liter. This condition can weaken bones, damage muscles, and further harm the kidneys. Managing metabolic acidosis early helps slow kidney disease progression, improve overall health, and enhance survival. This highlights the importance of timely specialist care and proactive treatment. When kidney function declines, the body's ability to regulate acidity is compromised. This leads to increased acidity in the blood, which in turn accelerates kidney fibrosis, interstitial scarring. This creates a vicious cycle. More acidity damages the kidneys further, leading to even greater acidity and further harm. Uncontrolled acidity not only worsens kidney health but also affects bone and muscle health. Acidic blood conditions can lead to osteoporosis, fractures, muscle loss, and increased insulin resistance, making diabetes management more difficult. Additionally, untreated metabolic acidosis has been linked to decreased survival rates in patients with kidney disease. The treatment for metabolic acidosis often involves sodium bicarbonate. A 2021 study observed 1,241 patients with chronic kidney disease between 2011 and 2013, focusing on those who started dialysis during this period. Of the participants, 677 received sodium bicarbonate therapy. Over a 3.5-year follow-up, the mortality rate for patients taking sodium bicarbonate was 13.6%, compared to 21.2% for those who did not. This indicates that sodium bicarbonate therapy reduced mortality by 35.88%. Sodium bicarbonate, commonly known as baking soda, plays a vital role in neutralizing acidity in the body. Beyond its household uses, such as baking and soothing heartburn, it has significant medical applications, particularly in managing metabolic acidosis in kidney disease patients. Baking soda, also known as sodium bicarbonate, is used for a variety of purposes, such as eating, cleaning, and more. If you look at the back of baking soda packages under active ingredient, you'll see it says sodium bicarbonate, as shown in the picture. Its purpose is often listed as an antacid, meaning it's used to relieve heartburn. Now, there's something to be cautious about here. If you search for sodium bicarbonate on Google, you may come across the abbreviation NTSS. When I searched for it on Google, a range of medications appeared, as shown in the picture. When I typed sodium bicarbonate pill, the first result was NALNST, branded as an antacid. There are many similar medications available. Common ones include Tums, which is based on calcium carbonate rather than sodium bicarbonate. Calcium carbonate, being a calcium-containing compound, can actually worsen atherosclerosis in kidney patients. Therefore, those with kidney issues should avoid calcium carbonate. However, there are situations where calcium carbonate is prescribed to some kidney patients, but those cases are more complex, so I'll skip over them for now. For conditions like acid reflux, which we're discussing today, sodium bicarbonate is preferable, as shown in the picture. Some patients might ask, isn't sodium harmful for kidney patients? Indeed, there's sodium in sodium bicarbonate, but it's different from sodium chloride, table salt. Sodium chloride, which is salty, can cause edema, swelling, while sodium bicarbonate doesn't have the same effect. Therefore, sodium bicarbonate is safe to take, so you don't need to worry too much about it. For kidney patients, if you're wondering whether you need sodium bicarbonate, you can find out through blood tests. At my hospital, we review blood test results such as the Comprehensive Metabolic Panel, CMP, or the Basic Metabolic Panel, BMP. In these tests, there's a value called carbon dioxide or CO2, which represents bicarbonate levels. Even though it's called carbon dioxide on the test, it's essentially bicarbonate, HCO3. Different labs may use varying terms like CO2, HCO3, or carbon dioxide, but they all refer to the same thing. If this value is below 21, consult a specialist to determine whether you need sodium bicarbonate supplementation. However, if your kidneys are healthy and the value briefly drops due to temporary conditions like intense exercise or metabolic changes, your body will likely recover within a day without needing bicarbonate supplements. Many people believe kidney damage is irreversible and that there's no way to stop kidney function from deteriorating. Unfortunately, even some internal medicine doctors think this way, often leaving patients untreated until they need dialysis and are referred to a nephrologist. However, there are many ways to slow kidney damage or prevent it from worsening, including treatments that protect blood vessels and reduce the risk of stroke or heart attack caused by atherosclerosis. If you have kidney issues, diabetes, high blood pressure, or symptoms like proteinuria, protein in urine, or hematuria, blood in urine, it's important to act early. Such symptoms indicate significant kidney damage has already occurred. Early and appropriate treatment not only improves kidney function but also enhances overall health and survival rates. Therefore, please seek timely and proper medical care.